Good evening, everyone. Welcome to the Masterclass in Rheumatology. Recent years, we have witnessed tremendous advances in the management of ankylosing spondylitis thanks to our greater understanding of the disease, its mechanisms, and the availability of novel therapeutic molecules in our armamentarium to combat this serious disease. Today, let's have a glimpse of the various advances in the treatment of ankylosing spondylitis as they stand in 2022. Ankylosing spondylitis is a chronic systemic inflammatory rheumatic disease affecting the axial, girdle, and peripheral joints and enthesial sites, often with extra-articular manifestations. The term ankylosing spondylitis is derived from the Greek language. Ankylos meaning bent, joint fusion or stiffness in today's nomenclature, and spondylos meaning spinal vertebra. Ankylosing spondylitis is predominantly a male disease with the male is to female ratio being 3:1. However, in the recent literature, these ratios are now getting obscured and the male and the female ratio now stand at 3:2. Ankylosing spondylitis affects 1 to 3% of HLA-B27 positive individuals. However, more than 95% of ankylosing spondylitis patients are HLA-B27 positive. Ankylosing spondylitis is the prototype of all spondyloarthropathy. Spondyloarthritis is not a concept encompassing various distinct rheumatic conditions as previously believed, but instead a single disease with heterogeneous phenotypic profiles that should be taken into account in clinical practice. So this was the older classification, what was known as the seronegative spondyloarthropathy, which included ankylosing spondylitis, psoriatic arthritis, reactive arthritis, arthritis associated with IBD, and undifferentiated peripheral disease as distinct entities and not under one umbrella of spondyloarthropathy as it is being done now. So let's have a look at the presentations of spondyloarthropathy. The patient often presents with inflammatory back pain, asymmetric mono or oligoarticular involvement, enthesitis, dactylitis. So I want to pause for a minute and talk to you about the concept of inflammatory back pain. This is a single most important concept in understanding spondyloarthropathies. So it's a chronic back pain of more than 3 months. The IBP criteria are fulfilled if 4 of the 5 following parameters are present. The pain is insidious in onset. Pain occurs usually at night, that too commonly in the second half of the night, often waking the patient from sleep. The age at onset is less than 45 years of age, meaning thereby that these are young patients. It improves with exercise and there is no improvement with rest. So this is in contradiction to the mechanical back pain, which may have an acute onset or an insidious onset, has no relationship to pain at night, can occur at any age. The mechanical back pain actually worsens with exercise and improves with rest. So hence, it's very important to identify inflammatory back pain in patients who present with this problem to us. Enthesitis is the anchoring pathologic lesion in ankylosing spondylitis. Enthesis is again derived from a Greek word meaning putting in or insertion. And enthesitis is inflammation of enthesis, the site of tendon and ligament insertion into the bone. In a simple way, we can say this is a kind of insertional tendinitis. Dactylitis is inflammation of the finger and the toes, presents as sausage-shaped digits. You can see in the images very clearly here. Once you have seen this image, there is no way you could miss such a patient in your clinic. It is a swelling of the fingers that causes a sausage-shaped appearance. The underlying pathology is tenosynovitis and peritendinitis tissue edema leading to this condition. We said that this disease often has extra-articular manifestations since it is a systemic disease. The extra-articular manifestations of ankylosing spondylitis include acute anterior uveitis, in which the patient presents with reduced visual acuity, eye pain, lacrimation, and photophobia. And incidentally, anterior uveitis is the commonest extra-articular manifestation of ankylosing spondylitis. Inflammatory ulceration of the ileum and the colon may be seen on endoscopy, but this is usually asymptomatic. Inflammation in the heart can lead to aortitis, aortic regurgitation, conduction abnormalities. Deposition of amyloid protein in renal glomeruli can lead to secondary amyloidosis. Compression of the sacral nerve roots innervating the bladder and the rectum can lead to bladder and bowel incontinence. And then the lung, it can cause apical lung fibrosis. The laboratory findings, as we already discussed, include HLA-B27 positive status, elevated biomarkers of inflammation, CRP and ESR. On imaging, sacroiliitis is evident either by X-rays or on MRI. Sacroiliac joint is the commonest joint involved in ankylosing spondylitis. And on imaging, there may be evidence of new bone formation in the form of syndesmophytes or ankylosis. So we have seen that what is ankylosing spondylitis, how can a patient with this problem present to us in the clinic. Now let's have a look at the treatment recommendations for this disease. The goal of treatment is to alleviate symptoms, improve functioning, maintain the ability to work, decrease disease complication, and forestall skeletal damage as much as possible. The treatment of these patients should be tailored according to the current disease manifestation, whether it's an axial disease, peripheral disease, enthesial disease, or has extra-articular manifestation. The level of current symptoms, clinical findings, prognostic indicators, and general clinical status of the patient in terms of age, gender, comorbidity, concomitant medications, and psychosocial factors. Optimal management of ankylosing spondylitis requires a combination of pharmacological and non-pharmacological treatment modalities. The non-pharmacological treatment modalities include patient education, exercise, and quitting smoking in patients who smoke. Let's have a look at the recommendations for the pharmacological management of ankylosing spondylitis. For symptomatic patients, non-steroidal anti-inflammatory drug is the first-line drug treatment up to a maximum dose while taking risks and benefits into account. Continuous NSAIDs are preferred over on-demand NSAIDs. However, in stable axial spondylopathy, on-demand treatment with NSAID is recommended over continuous treatment. Efficacy of NSAIDs in the treatment of ankylosing spondylitis has been well demonstrated. There is less radiographic progression after 2 years of continuous versus on-demand NSAIDs. For peripheral predominant spondyloarthropathy, the treatment recommendation is local glucocorticoid injection if less than or 2 joints are involved, and conventional synthetic disease-modifying anti-rheumatic drug, sulfasalazine. However, conventional DMARDs are largely not effective for the treatment of patients with ankylosing spondylitis. There have been remarkable advances in the management of ankylosing spondylitis over the last 2 decades. The discovery of biologic drugs and more recently the JAK inhibitors has transformed the management of patients with axial SpA. 5 anti-TNF agents are currently approved by European Medicines Agency and FDA. Next. These include adalimumab, certolizumab, etanercept, golimumab, and infliximab. Of these, all except certolizumab are available in India and are approved by the Drug Controller of India. IL-17 inhibitors, secukinumab and ixekizumab, are also approved by EMA and FDA for management of axial spondyloarthritis. Anti-TNF treatment initiation is recommended after failure of treatment with 2 different NSAIDs for at least 4 weeks. ESA's EULAR in addition recommend disease activity cutoffs to start anti-TNF treatment with either a BAS die of more than equal to 4 or a AS DAS of 2.1. You must be wondering what BAS die and AS DAS, what is this Greek and Latin? These are nothing but these are very simple tools which we can use in our clinics to determine the level of disease and follow up our patients and treat them to target. They can very easily be done by the use of online calculators these days. Of the various anti-TNF agents, anti-TNF monoclonal antibodies should be preferred in patients with concomitant inflammatory bowel disease or recurrent iritis. IL-17 inhibitors are recommended for patients with active disease and heart failure, demyelinating disease, when there are contraindications to use of anti-TNF or primary non-responders to anti-TNF. However, IL-17 inhibitors are not recommended for patients with IBD or recurrent uveitis. This slide shows us at a glance the EULAR 2016 recommendations for the management of axial spondyloarthropathy. In a patient with a clinical diagnosis of axial spondyloarthropathy, all patients should receive health education, regular exercise, and should quit smoking if they are smokers. If the patient is symptomatic, he should be started on a non-steroidal anti-inflammatory drug in the maximum tolerated dose and should be reevaluated after 2 to 4 weeks. If there is a sufficient response, the treatment is continued. In case of insufficient response, with at least 2 courses of NSAIDs, it is considered as failure of phase 1 and one should go to phase 2. In the phase 2, there is lack of efficacy and or toxicity of the patients in phase 1. In patients with purely and with these patients having a AS DAS of more than equal to 2.1 or a BAS die of more than equal to 4 and a positive rheumatologist opinion with a purely axial disease, next they should be started on a biological DMARD, and the current practice is to initiate TNF inhibitor therapy. In case of mainly peripheral symptoms, consider local glucocorticoid injection and consider sulfasalazine. If there is contraindication to this treatment or there is lack of efficacy, then we come back to the same situation of starting a biological DMARD, and the current practice is to initiate TNF inhibitor therapy. Having done that, the patients are evaluated after at least 12 weeks. If there is a change in AS DAS of more than equal to 1.1 and a BAS die of more than equal to 2, treatment is continued. If the change is less than this, it is considered as a failure of phase 2 and one needs to go to phase 3. In the phase 3, next, one should switch to an TNF inhibitor or IL-17 inhibitor. Again, reevaluate the patient after at least 12 weeks, and if the improvement criteria is met, continue with the treatment. If the improvement criteria is not met, again resort to switching. This is the algorithm for the 2019 American College of Rheumatology treatment recommendations in ankylosing spondylitis. Active axial disease, NSAIDs, physical therapy, determine additional disease manifestations. For peripheral predominant arthritis, despite NSAIDs, local glucocorticoid injection if less than equal to 2 joints are involved, or sulfasalazine. Isolated sacroiliitis or enthesitis is treated with NSAIDs. Despite if these are non-responsive, one can resort to glucocorticoids. Just a warning here, avoid Achilles, patellar and quadriceps injection Enthesitis of these glucocorticoids. In case the disease is still active despite NSAIDs, the recommendation is for a TNF inhibitor. In case of Ang-Spond with the recurrent uveitis or with IBD, a TNF inhibitor monoclonal antibodies are recommended. For patients who have received TNF and are primary non-responders, the recommendation is switch to IL-17 inhibitors. For patients of active ankylosing spondylitis on TNF inhibitors who are secondary non-responders, meaning thereby that when the drug was initiated, they had an initial response followed by a lack of efficacy over a period of time. The recommendation is for an alternative TNF inhibitor. Next. This year, on 3rd, the EULAR updated 4 recommendations for management of axial spondyloarthropathy at its 75th annual meeting at Copenhagen, Denmark. These 4 recommendations are as follows. If there is history of recurrent uveitis or active IBD, anti-TNF monoclonal antibody should be preferred. For patients with significant psoriasis, IL-17A inhibitors may be preferred. The second change recommendation is more of common sense rather than scientific evidence. So if there is absence of response to treatment, one that should trigger a search for evaluation of the diagnosis and consideration of the presence of other comorbidities. For patients with persistently high disease activity, despite conventional therapy, TNF inhibitors, IL-17 inhibitors, or JAK inhibitors should be considered. The last recommendation given this year is, if the first biologic or targeted synthetic DMARD fails, switching to another biologic or JAK inhibitor should be considered. Next. Long-term efficacy of TNF blockers in ankylosing spondylitis over 8 years has been well demonstrated. Next. However, anti-TNF therapy over 2 years does not inhibit radiographic progression in ankylosing spondylitis. Next. Continuous long-term anti-TNF therapy might not lead to an increase of new bone formation over 8 years, so the results are better over a longer period of time. Next. IL-17 inhibition with secukinumab inhibits radiographic progression in ANG-SPOND as early as at week 104. Next. Certain novel targets have also been investigated as therapeutic targets for management in ankylosing spondylitis. Let's have a look at these. Molecules directed against B cells, T cells, integrins, villus, GM-CSF. Next. Interleukin 6, interleukin 1, and rank-lichen have not shown to be effective for management of ankylosing spondylitis. Next. Biological DMARDs inhibiting interleukin 17, next, are effective for management of axial SPA, psoriatic arthritis, and psoriasis. Previous, please. Biological DMARDs that inhibiting interleukin 12 and 23 are effective for management of psoriatic arthritis and psoriasis, while biological DMARDs directed against the interleukin 23 are only effective for psoriatic arthritis and psoriasis and Crohn's disease, but not against axial SPA. Next. JAK inhibitors are effective in management of, especially tofacitinib is effective in management of axial SPA, psoriatic arthritis, and psoriasis. Phosphodiesterase inhibitor apremilast is effective in psoriatic arthritis and psoriasis. Next. Next, please. Next. What about biosimilars in ankylosing spondylitis? In our country, we tend to use a lot of biosimilars as our patients often cannot afford the innovator molecules. As per the 2019 ACR recommendation, in adults with stable AS receiving an originator anti-TNF, ACR strongly recommends continuing treatment with the originator anti-TNF over switching to its biosimilar. However, biosimilars are now often prescribed as the first biologic drug treatment, and many patients have been successfully switched from original drug to the biosimilar. Switching from originator TNF inhibitor to its biosimilar is not inferior in terms of efficacy, safety, and immunogenicity. Biosimilars are now available for adalimumab, etanercept, and infliximab in India. Next. How can any presentation be complete without talking about corona and COVID? So what about rheumatic diseases and the risk of COVID-19? So these are the EULAR recommendations relating to this topic. There is no evidence that those with rheumatic disease have a higher risk of contracting the virus. No evidence that those with rheumatic disease have a worse course than general population. Also, there is no recommendation to withhold the use of NSAIDs, glucocorticoids, synthetic DMARDs, biological DMARDs in rheumatic patients without COVID-19. Next, please. What about anti-rheumatic drug treatments and COVID-19 vaccination? A very practical question which we are often asked in our clinics by the patient. No modification to either immunomodulatory treatment or vaccination is recommended in case of TNF inhibitors, IL inhibitors, low-dose steroid, sulfasalazine, hydroxychloroquine, and leflunomide. However, methotrexate, JAK inhibitors, abatacept, and cyclophosphamide require no modification. Fortunately or unfortunately, abatacept is no longer available in our country. Next slide. So what's the impact of TNF inhibitor or coronavirus infection? Next, TNF inhibitor or methotrexate patients do not have increased hospitalization or mortality versus patients without TNF inhibitor or methotrexate exposure. The COVID-19 Global Rheumatology Alliance, which is a huge registry of data of rheumatic disease patients who contracted the virus, has shown that anti-TNF treatment was associated with a decreased odds of hospitalization in patients with rheumatic disease. Next. The Secure Inflammatory Bowel Disease Registry reported anti-TNF usage was usually inversely associated with the secondary outcome of hospitalization or death. Next. So the message to the clinician is that in a patient with chronic low back pain of more than 3 months, which is inflammatory in nature, with associated HLA-B27 positivity or sacroiliitis, an early referral to the rheumatologist is required for further evaluation and planning of therapy. Next. To summarize, NSAIDs, TNF inhibitors, IL-17 inhibitors, and JAK inhibitors are the most effective forms of treatment in axial spondyloarthropathy. The choice of a particular drug should always take the safety and efficacy and different mechanism and different disease manifestations into account. Inhibition of structural damage progression may be possible with early and complete inhibition of inflammation. However, there is an unmet need with respect to treatment sequences in the management paradigm of ankylosing spondylitis. Apart from the NSAIDs and the biologics available for therapy, many newer molecules and newer targets are in various stages of research to evaluate efficacy and safety in ankylosing spondylitis. Thank you so much for your kind attention, and I'll be happy to take any questions. Is the role of sulfasalazine underplayed in the presence of JAK inhibitors? Actually, the problem is not one molecule or the other. I mean, if you go by evidence and if you go by the published literature, uh, there is not much role of synthetic DMARDs in ankylosing spondylitis. And the problem is economics actually. Most of these patients qualified for biologic treatment actually, and they cannot afford. So under compulsive circumstance, and insurance penetration in our country is not very good, and the insurance doesn't reimburse the outpatient patients actually. So under compelled circumstances, we do resort to using synthetic DMARDs. And I don't think that is totally unjustified in a country like ours. And even I have seen that in many of these patients do respond to therapy actually. Okay, while we are, sort of receiving some questions, let's try and make this little more interesting actually. Let me talk to you about something which I think I didn't cover in my symposium. And these are very interesting things. So the commonest cause of premature mortality, that is death, in ankylosing spondylitis is what? Most of us will be surprised to listen to the answer to this question. Anyone wants to take a pot shot at this question? It's like a reverse symposium. The speaker asking the audience about questions. Okay, the answer is it's premature cardiovascular disease, which includes myocardial infarction and stroke. This results from the fact that the chronic inflammation in rheumatic diseases like Ankylosing causes endothelial dysfunction, which leads to accelerated atherosclerosis, resulting in premature cardiovascular disease. But actually, the good news is that this risk is treatable now, actually. What are the future trends in preventing the disease in children? Wow, that's an amazing question, actually. Okay, I'll try and answer this question. It's a bit difficult for Rankspond, much more easier to answer this question in the context of rheumatoid arthritis, actually. So we need to understand that there are non-modifiable risk factors and modifiable risk factors for the disease. The non-modifiable risk factors are gender, male, age less than 45 years of age, and a family history, right? So these are non-modifiable and we can't do much about it. And genetics, of course, whatever genes we are born with, to wherever we are born, and all those things, whatever we come with is with whatever baggage we come. So we can't change that. So what about modifiable risk factors? The modifiable risk factors include smoking, which one can take care of. Second, infection. Third, injury. So any break in the barrier, like if there is a break in the barrier of the skin because of psoriasis, that can result in psoriatic arthritis. Similarly, if there's a break in the barrier with inflammatory bowel disease, that can lead to IBD-related spondyloarthropathy. So those are the things which we can little bit take care of and prevent these diseases from happening. It's very rewarding to treat all the rheumatic diseases now, and perhaps we are very lucky. We live in a very nice era of time when so much treatment has become available, and that treatment is available in our country, and it's pretty economical now. Even the price of JAK inhibitors with the generic versions coming in is so cheap. It's possible to treat most of our patients to target. The biggest challenge perhaps is that the patients don't reach in time. So more awareness, early referral, early evaluation, early diagnosis, that can all help in managing these diseases and preventing the complications of these diseases actually. The complications are not just, I mean, in terms of biology or biological functions. It's also there are a lot of psychosocial complications. For example, if the bread earning member of the family gets struck with the disease, his livelihood is lost and the whole family goes down. So there are a lot of implications. So it's very rewarding to treat these patients in the clinic, and you see them getting back to work, getting back to their employment, and moving on with life. I'll tell you a very small, interesting story. We'll take up this just a minute. All of us heard of Dr. Christian Barnard, the famous South African surgeon who performed the first successful cardiac transplant in the year 1967. After that heroic surgery, we never heard of him again, actually, as if professionally he just disappeared, actually. He did not disappear, friends. He had rheumatoid arthritis and he could not operate again in his life. So it was like a professional death sentence. But today we have such good treatments that we can prevent such stories from getting repeated. Okay, let's move on to the next. How to differentiate Sherman from early mild? I think we'll just have to go by the history, the investigations, and demonstrate the things like if you can see mild or severe, AS will have its characteristics. There's going to be history. There's going to be evidence of sacroiliitis by any imaging modality, X-ray or MRI. Incidentally, MRI is the gold standard of imaging of sacroiliac joints actually. And sometimes what we do in very early disease, or sometimes patients are very claustrophobic, they don't want to go into MRI machines, we use the bone scan radioisotope radionuclide scan actually for demonstrating increased uptake at the SI joint and the other joints. I think so. Let's all go back with the impression that ankylosing spondylitis is a very treatable disease. It needs to be diagnosed in time. Early treatment can prevent deformities and other complications which we see, and a healthy life is possible with this disease. Thank you.